And we're going to talk a little bit about medications for disease management. While this disclaimer is up there, I will tell you this is a very broad topic. So I chose some medications that I think are key to patients with PKD and then just patients with CKD in general. And I also talked to one of my colleagues who's a transplant pharmacist for her recommendations. So that's how I came up with what I chose to talk about today. But please put in questions if you want to, if I don't talk about a medication that you really wanted me to talk about, put that in the chat and I'll do my best when the presentation is over. So we're just going to do it that way. And I do not have any financial relationships to disclose. And so just to tell you a little bit about me, I'm an associate clinical professor with the Auburn University Harrison College of Pharmacy. I joined the college in 2015. So I am in Alabama. I practice pharmacy when I am not teaching in the classroom at the University of Alabama at Birmingham. And I have the privilege of working in a chronic kidney disease clinic that has 5 nurse practitioners. So on the days that I get to be there, myself and the nurse practitioner will see all the patients that are scheduled that day. In the picture there, the two of the women to the left of me are the previous medical director and the current medical director of our clinic. And then the lady to the far right is the nurse practitioner who handles all the PKD patients who are taking Janarki. So I do have the privilege of working with many patients who have PKD when I get to be with Dr. Ferris in her clinic. So our objective today is to talk about some medications used to treat PKD and CKD, to understand some medications used post-kidney transplant, and then recognize medications to avoid when you're being treated for PKD and post-kidney transplant. So when I thought about this topic, when I talk to my patients, I think a lot of them don't understand how medications work. When I talk with my family members, and when I think about myself before I went to pharmacy school, I don't think I understood how medications work. So I thought a little background on how medications work might help give you knowledge to help you as you manage your disease state. So I think some of my patients think this: when they take a drug, they imagine a science experiment with, stuff bubbling out of a vial. And you know what? That's a reasonable thought. Drugs are chemicals. This is a chemical reaction that you see going on with the purple liquid in that flask. So is this what's happening when I take a medication? So let me just tell you, what we're seeing here is called inorganic chemistry. And medications are all organic chemistry and biochemical reactions. So that's a little different. So how do drugs work in the body? And I'm going to ask real quick, if I use do y'all see my cursor? Okay, perfect. So we're going to look at this figure for just a minute. So, and to give an example, what I came up with, let's just imagine that we hurt ourselves, and my mouse disappeared, there it is. But we hurt ourselves and our body's going to produce some opioids. We have naturally produced opioids in our bodies, and those opioids are going to interact with opioid receptors and cause something to happen in a cell. And that's just what happens when we hurt ourselves. Let's say we hurt ourselves pretty badly. We have to go to the ER, we have surgery, and we take morphine or codeine or hydrocodone. In this case, we have what our body produces. And then we also have a drug that we have swallowed or been injected into our vein. And this drug reacts with this same receptor as the natural substance. But because we have the drug, we get more cellular activity from that medication. And then some medications block the receptors. So naloxone is the reversal agent. If you overdose on opioids, we can give you naloxone. And what naloxone does is it hits those same receptors, but blocks the action of both the substance our body makes and any drugs we might have taken. So these are, as I said before, organic chemistry reactions, not inorganic chemistry reactions. Well, then you might wonder, how do these drugs get to those receptors that are on the cell surface? So again, we're going to look at this figure, and ADME stands for absorption, distribution, metabolism, and elimination. So you swallow your medicine, and in your stomach, the medicine dissolves so that you have the individual drug particles released, and those get absorbed in your small intestine. So first, your drug has to be dissolved and absorbed into your small intestine, and then it is distributed throughout your body in your bloodstream. So that's what these arrows are. After it has done its work at its site of action, many drugs go through metabolism. So they go through the liver and they get metabolized into different compounds that are not active in your body. And then they are eliminated. Most drugs are eliminated through our kidneys. A few drugs are not eliminated through our kidneys and come out in the feces, but most come out in our urine, which is key to patients who might have kidney disease. And then, okay, so we've talked about like what the goal is when we take a medication, but then we also know about side effects. And so what are side effects? Where do those come from? So side effects are the unwanted effects from a particular drug. So I want, when I take morphine or codeine, to not feel pain. But sometimes the drug interacts with other receptors. So there are opioid receptors in our GI tract. So if we take morphine or hydrocodone, we get pain relief in our brain, and then we get constipation in our GI tract. So sometimes we can predict side effects because there's interaction with receptors other than the ones we were going for. And then we can also have a side effect because the drug works too well. So let's say you need to be on a blood thinner because you've had a stroke or you've had a blood clot or you have atrial fibrillation. Well, too high a dose of a blood thinner or too much blood thinner in your bloodstream can lead to bleeding. Some of us have high blood pressure, and so you're on blood pressure medicines. Too much blood pressure medicine, you get low blood pressure, which is an undesired effect. You get dizzy and lightheaded, and maybe you have more falls. So what causes a drug to work too well? Well, one, the dose could be too high, or you have more drug in your bloodstream than we would have anticipated because there's a drug interaction that's increased the amount of drug in your body, or the drug isn't eliminated as quickly because, say, you have chronic kidney disease and your kidneys aren't eliminating like they used to. And then some side effects we can't predict. And so how do we know about side effects? We don't know why the side effect happens. We can't tell you, well, it's because your drug is interacting with the receptor in your GI tract. How do we know about those side effects? And that all comes from the clinical trials that drugs undergo. So I don't want to spend a lot of time on this slide, but are 3 phases of human trials before a drug even goes to the FDA to get approval. And in those trials, they look for safety signals. So if a significant number of patients who took the drug versus the patients who didn't take the drug had a particular bad outcome, that gets listed as a side effect of the medication. And when you hear an ad for the drug on TV, they're going to list all those side effects that happened in those trials. When I go in the drug databases and look, it's going to list all of those side effects. And that's key for us in just a minute. And then lastly, I just want to talk about 2 different ways there can be a drug interaction, just so that we don't get too deep in the nerdy pharmacy stuff that I like so much. So drug interactions is when one drug affects the absorption, distribution, metabolism, or elimination of another drug. So when we think about absorption, if the pH in your GI tract is different, some drugs need it to be very acidic, and so they don't get absorbed as well when we're taking like Nexium, a proton pump inhibitor, or Pepcid. So like if you're on oral iron and you're on a proton pump inhibitor, I know as the pharmacist, your kidney doctor knows, your advanced practitioner knows that you're going to get less iron absorption in that situation, but it's okay to take them both, even though it's going to affect the absorption of oral iron. And then metabolism, I just use statins as the example. So most statins, so this is like simvastatin is the example I used here, but any drug that ends in statin, you might see a little label on your medication bottle that says don't take with grape juice. So what's that about? Well, grapefruit uses the same metabolic pathway as the statin. So if you drink a lot of grapefruit juice or you eat a lot of grapefruits and you're on a statin, the statin will not be metabolized as quickly as we would have anticipated because the grapefruit is using that same pathway. So that's the reason for that interaction. There's a similar interaction with simvastatin and a common blood pressure medicine, amlodipine. So if you need to take those two drugs together, we don't give you more than 20 milligrams of simvastatin, and that way it'll keep you from having more side effect from the interaction. So then I wanted to talk just a little bit about natural products. At least my patients, I have quite a few patients who feel that natural products are safer. And I understand why you think that. It's called natural. And, you know, medications were made in a lab environment, and so that can be kind of scary. So let's talk about natural products. Well, first, most of our prescription drugs originally came from plants. So 3 big examples: digoxin, which is a medication for patients with certain heart conditions, comes from the foxglove plant. So I wish I could grow foxglove in Alabama, but I'm never successful. Very pretty plant. But, you know, if I had it and my dog ate it, it could kill my dog, because my dog doesn't need digoxin. Aspirin comes from the bark of the willow tree. And then we've already talked about morphine and codeine, but they all originally came from the poppy plant. So how do natural products act in our bodies? Well, they interact with receptors on the surface of the cell, and they either enhance the activity within the cell or they block activity in the cell. When we swallow them, they are dissolved in our stomach, absorbed in the small intestine, distributed through the bloodstream. They are metabolized by our liver, and they are eliminated either in the feces or the urine. So our bodies don't actually know the difference in a natural product and a prescription medicine. They act the same, and they behave the same, and they're treated the same by our bodies, because these are all just biochemical reactions. So what is the difference? So the FDA regulates prescription medications as drugs. And so there are rules about the ads for drugs. There are rules about what the drug manufacturers can say. There's a whole bunch of data that we have at our fingertips about what might happen in patients who have chronic kidney disease as their kidney disease progresses. What dose should we give? What drug interactions exist? On and on and on. Natural products like supplements, like St. John's wort, they're regulated as a food. So they can't say that they will treat anything, but they also don't ever have to say that they might be dangerous. And we don't have to have all the evidence behind them. So the truth is, for my patients with chronic kidney disease, I don't know many times if the natural product, if you're going to have side effects as your kidney disease gets worse, because I don't actually know how it's metabolized and eliminated in your body. I don't know if the natural product might cause kidney damage. There's a lot of natural product databases. And if I have a patient who wants to take a natural product, I will look to find all the evidence that I can to help them know if it's safe or not. But many times I don't know. And so my recommendation is you just avoid natural products, because we don't know if you're going to have a side effect because you have reduced kidney function. And I'm going to talk about post-transplant later. Post-transplant, I wouldn't take any natural product, any supplement, unless I had talked to my transplant team, just to make sure there's no drug interactions between whatever you might take. That includes prescription medications and your anti-rejection medicines. And I know one patient on the call here has had 3 transplants, so maybe he has some other tips he could share as we go along, because he's actually lived this. So now like I said, I chose some drugs that I think are commonly used for patients with PKD that it might be helpful for you to know a little bit more about. And we're going to start with tolvaptan, which is brand name is Janarki. And it has been proven in the clinical trials to slow kidney function decline in adults who are at risk of rapidly progressing ADPKD. What does it do? It blocks vasopressin receptors. And the positive effects are from blocking vasopressin receptors that are on the cysts. However, we also have vasopressin receptors in the kidneys. And so it blocks those as well, which is why you go to the bathroom a lot, because it really increases your urination. And if you don't keep up with your water intake, it can change the sodium levels in your body. So that's why you need to get your blood work checked. And then the other side effect is liver disease. Now, we don't know why tolvaptan can cause liver disease, but it was a safety signal that was seen in the clinical trials when tolvaptan was used to treat PKD. And then as far as drug interactions go, CYP3A is one of the metabolic pathways in our liver, and that's the same pathway that tolvaptan uses. So you need to avoid strong inducers of CYP3A. And you might be thinking, well, what are strong inducers of CYP3A? There's not many of them. Your kidney doctor would be aware of this, and they're rarely used. There's some antifungal medications. If you have a severe fungal infection and are in the hospital, then you might have to take one of those medications. And then a couple of the HIV medications are strong inducers of CYP3A. But again, if you ended up with both disease states, you would have infectious disease providers who are aware of the interactions, and you would have your kidney doctor. So I think we can, as your healthcare providers, can help you avoid that drug interaction. So now I'm just going to move into some other medications that are often used. ACE inhibitors and angiotensin receptor blockers, so that's ACEs and ARBs, are drugs that slow progression of CKD for patients who have protein in the urine. So I do have some PKD patients who are on tolvaptan and they are on an ACE or an ARB because they do have some protein in their urine. These drugs are also a first choice for anybody who has high blood pressure. So there's a lot of non-kidney patients who are on these medications, and they have shown great benefit for patients with heart failure. So what are these drugs? So the ACE inhibitors all end in pril, and the ARBs all end in sartan. So really quickly, the big side effect we worry about is increasing potassium. And so we check your labs to make sure your potassium is in range. The prils can cause a cough. Both drugs can cause a severe allergic reaction. That's very rare, but if you're on one of these medications and your lips swell or your tongue swells, then you need to go to the ER and have that treated. And then also these medications are harmful to a developing fetus. So if you want to become pregnant, these are not good choices for you. Another drug class that we use a lot in patients with kidney disease are mineralocorticoid receptor antagonists. So some of you may have heard of spironolactone or eplerenone. There's a brand new drug that came out this year called finerenone. Its brand name is Corindia. All these drugs will lower blood pressure, but they're not the first choice for us in lowering blood pressure. Spironolactone and eplerenone, again, have great benefits for patients with heart failure and patients with CKD. And then finerenone has been proven to slow progression of CKD. Again, you're going to get increased potassium with these medications. And I have patients on an ACE and spironolactone or an ARB and spironolactone. And so I just have to watch their potassium closely. Spironolactone is a steroidal medication, so you can have some breast swelling, which men generally do not enjoy, impotence, and then changes in menstrual cycles for women. Finerenone does not have those adverse effects. So I just talked about two medications that can raise your potassium. And over the last 3 years, we have two new drugs on the market that really help patients stay on these important medications because they bind potassium. So patiromer, which is brand name Velteza, or sodium zirconium cyclosilicate, which is brand name Lokelma, they both bind potassium in your GI tract so that it's eliminated rather than absorbed. And as I mentioned, it helps patients stay on their ACEs, ARBs, and mineralocorticoid receptor antagonists. It's a powder that you mix in water. It's got a little bit of a texture to it, so some patients find that unpleasant, but it doesn't have a taste. It needs to be separated from other medications. So I do have some post-transplant patients that are on a potassium binder, and I definitely make sure that they separate it from their other medications. So that's the only bad part of potassium binders, is you have to take it separate, so it's a little harder to remember to take. And then real quickly, a couple of other blood pressure medicines that are often used in patients with CKD, but could be a little bit, you would have to keep an eye on it if you're also on tolvaptan. We have the thiazide diuretics, which is chlorthalidone, hydrochlorothiazide, and indapamide. These are, again, first-line choices for anybody who has high blood pressure. They are a very weak diuretic or water pill. So you get a little bit more urination, but not a lot. Side effects, because of the way they work in the kidneys, you can get some electrolyte changes like low potassium or high calcium. If you have gout, it can increase the risk of a gout attack. And then for drug interactions, so this is an example of an elimination interaction. So lithium uses the same elimination transporter as the thiazide diuretic. So you can get an interaction if you have to take lithium. Lithium is a great drug for patients with bipolar disease. So that's a more rare disease, thankfully. And then real quickly, I want to talk about loop diuretics, which are really strong diuretics that we use for patients who have swelling or shortness of breath, which can happen if you have advanced chronic kidney disease or you have heart failure. We have to be very careful with loop diuretics in patients who are also on tolvaptan. We've already mentioned how tolvaptan increases your urine output. So the loop diuretics can also, but I have seen a patient or two who were on both. Again, you can get electrolyte changes, and because the loop diuretics are stronger and cause a lot more water or urine output. Like this week in Alabama, it's been like 101 heat index. So if you worked outside a lot and you didn't drink water, you could end up dehydrated. And then I'm going to end with a couple of the medications used to treat diabetes. We have the glucagon-like peptide receptor agonist, which I'm going to call GLP-1s. All of these, except for the brand name Rybelsus, which is a semaglutide brand name, are injectables. Rybelsus is an oral semaglutide. The GLP-1s are becoming much more popular. They do lower blood sugar in patients who have diabetes, but they also reduce the risk of cardiovascular disease. And they are being studied right now for benefit in patients with kidney disease. So the cardiovascular disease trials showed some benefit for kidney disease, and now they're studying it specifically in patients with kidney disease. These drugs are also used for weight loss. The two brand names with the stars beside them, Saxenda and Wegovy, are specifically for weight loss. The other side effect is you have an increased risk for thyroid tumor. So if you've had, thyroid cancer, this would not be a good choice for you. And then of course they're injectables, so you can have reactions where you inject it.
Rebecca, we do have like a 7-minute warning, but we don't have a lot of questions yet. So maybe you can go a little over, but if people have questions, please enter them in the chat window. Thank you.
Sure thing. Okay. So metformin lowers blood sugar in patients with diabetes, and it's first line for patients with diabetes. The key with metformin, one of the rare side effects is a condition called lactic acidosis, and that risk increases as your kidney function decreases. So I have patients who were on metformin, it worked very well for them, but then their kidney function dropped below 30 and we had to stop metformin and put them on something else. So really quickly, how can you be prepared for a transplant from a medicine perspective? So I'm going to go through this a little more quickly. We're going to talk about each of these. One, just take your medications. So after your transplant, you're going to have even more medications. So having a good system that works for you for taking your medications before the transplant will help you post-transplant. I showed a couple of different ways, that my patients use. We have a couple of pharmacies that send out your medications in strip packs. So you would just have like a morning, maybe a noontime, maybe an afternoon, evening pack, whatever you take, or you can organize them yourselves in a pill box. Slowing CKD progression to extend as much as you can to extend the time till you need a transplant. So if you're on tolvaptan, take your tolvaptan, drink your water, get your labs checked so we make sure that the tolvaptan is safe for you. If you're on a pril or a sartan or a mineralocorticoid receptor antagonist, take them. And if your potassium gets out of whack, take your potassium binder. If you have high blood pressure, control that high blood pressure. Take your medicines. If you've been asked to limit salt, limit your salt intake. If you have diabetes, control your diabetes. If you're overweight, lose weight. If you move more, all of these things will slow CKD progression and help you delay transplant and have a more successful transplant. Anemia is important if you're headed towards transplant because blood transfusion increase the antibodies, your antibodies in you, which makes the match more difficult. So if you develop anemia and your kidney doctor wants you to take oral iron's a little hard to take, but do your best. If you're told to take injections like the ESA Aranesp that I show there, get your injections. If you need IV iron, take your IV iron. Anything you can do to avoid a blood transfusion increases your chance of success with your transplant. Phosphorus, this was from my friend who's a transplant pharmacist. Managing phosphorus decreases your risk for long-term issues with hyperparathyroidism. Treating hyperparathyroidism adds more medications to your medication list. So if you've been told that your phosphorus levels are high, you can limit high phosphorus foods. Some easy foods to limit are dark sodas, processed foods. And then if you're told to take a binder, take your binder. If I showed this, if you look at your drug label and you see like sodium phosphate higher up in the list, then that's a drug that has extra phosphorus added to it as a stabilizing agent. And then I won't go over this much, but if you have to start a dialysis therapy before you get a transplant, preserving your native kidney function is helpful. So if you can choose a peritoneal dialysis over hemodialysis, there has been shown some benefit. That's not possible for everybody. So that's something you would discuss with your kidney provider. And then after kidney transplant, all transplant teams have a pharmacist. So you have someone there who will help you understand your medications. And so the most common immunosuppressants that I see are tacrolimus or tacrolimus, prednisone, and then mycophenolate. Again, I mentioned this before, but don't take any other medications or natural products without talking to your transplant coordinator or your pharmacist first. And then really quickly, I am assistant director of the Advancing Kidney Health Through Optimal Medication Management Initiative, and we have several patients who are involved in our initiative and have been very helpful. Our goal is to improve the lives of patients with kidney disease through optimal medication management. I put our website there. We are working on a video that explains how a pharmacist can work, with patients to help you with your medications. I wanted to show the video today, but it's not quite finished. So I've given you the website there so you can check it out. It should be published in the next couple of weeks. And I think that's all I have. So I see one question. Any reason why an ADPKD patient would have low phosphorus levels? So in my experience, and I don't know specifically for ADPKD, but low phosphorus levels are usually from malnutrition. So poorer nutrition can cause low phosphorus levels. Protein is full of phosphorus. So I never want my patients to, so the question was HCTZ. I don't think HCTZ affects phosphorus levels. It affects potassium. It can affect sodium in certain situations. It affects calcium. Okay, I have a question about Prilosec. Anything to replace this because it is tough on my kidney transplant? You have to take Prilosec because of dysplasia. I think in your situation, you're pretty much going to have to take a PPI. So Prilosec is one of the PPIs, and it's one of the ones that we feel, we don't really know if PPIs are safe or unsafe for patients with kidney disease. There's some weak evidence that it might be unsafe, and then there's some more weak evidence that it might be safe, but Prilosec is one that's never been in the unsafe category. So that's usually the one that we would choose for patients. Do patients on statin have to stop tolvaptan more frequently? That's a great question. And so I think overall, no, but the issue there is statins can affect your liver and tolvaptan can affect your liver. Now, it's a rare side effect in both cases, but it's possible your statin would raise your liver enzyme levels, and that would make you also stop your tolvaptan. And so I'm going through these questions pretty quickly. If I don't fully answer your question and you have follow-up, please put that in the chat also. Maybe I answered them too quickly. Oh, wait, no. Have you heard of statins increasing blood glucose levels? Let me think real quick. Do we have to worry about topical steroids like Flonase? No, you do not have to worry about topical steroids like Flonase. There's very little systemic absorption from those. Statins, I haven't heard specifically of statins increasing blood glucose levels. There is some evidence that the thiazides can slightly increase your blood glucose levels, but I haven't heard that with statins. And just so based on the recent lipid statin guidelines, every diabetic should be on medium to high dose statin. Okay, so let's see, when other doctors want to add or change a script, do I need to get it cleared? I would say yes. I would always get it cleared by your transplant team, because other providers, other doctors are wanting to do their best for you, but they don't always know all the ins and outs of your transplant medications or of your transplant status, like how your transplanted kidney is doing. So I find in my patients that other providers are trying to do their best for their patients, but they don't think about kidneys. So I have a lot of patients with kidney disease who get full dose antibiotics, which just causes more side effects. So I would say yes, especially if you have a portal account and you can quickly just send them a little message. Okay, so if you are on lisinopril and HCTZ and need to stop HCTZ to start tolvaptan, which is the best second hypertension med to start, I would say amlodipine in that situation. I have this fear that Rogaine for hair loss will increase cyst if they increase hair growth, since it is topical. Okay, so Rogaine is actually a blood pressure medicine. So minoxidil is the medication that Rogaine is. And minoxidil is used for high blood pressure. And we just noticed that people with high blood pressure also have a lot of hair growth. And I actually do have one patient with PKD on minoxidil for blood pressure control and just has amazing hair. So I would not be concerned about cyst growth, because the way it grows your hair has nothing to do with how your cysts grow. But that's a great question. Are there general guidelines for PKD patients? Yes, there are PKD guidelines out there. In fact, there are guidelines specifically on the use of tolvaptan in patients with PKD, because that's the first drug we've had to specifically target that disease state, which has been very exciting for us. Any recommendations for hair thinning? And I'm sorry, I am not a transplant pharmacist, so I don't have any specific information other than to say biotin, which is a B vitamin, can sometimes help with hair growth, hair health, but I'm not sure that it's super effective with the anti-rejection drugs. I'm sorry, there's another one. I just need to scroll. There we go. If irbesartan starts working from long use, will losartan work? I wish I could remember off the top of my head, and I can't. There's a few of the sartans that seem to be a little more potent than others. I think losartan's in the lower potent group, and I felt like irbesartan was in the higher potent group. So I would change irbesartan to like telmisartan if irbesartan stopped working. It's also, and there's a lot of reasons why irbesartan might stop working. There's a lot of reasons why it might look like irbesartan's not working when irbesartan is still working. So it might be you need another blood pressure medicine. So I would talk to your provider about what they think is going on with the irbesartan. My point there is, it doesn't seem like long-term use with the ARBs or the ACEs that they stop working over time. Okay, do lots of transplant people take fluconazole? I take it always. So if you have a certain infection post-transplant, then yes, you will take fluconazole for the rest of your life as secondary prophylaxis against that infection. So not everybody, it's everybody who gets that particular infection. And fluconazole, fluconazole is not a strong CYP3A inducer, but the other azoles are. Most common side effect that tolvaptan complain of besides going to the bathroom frequently. I really just hear going to the bathroom frequently and then needing to drink water. I'm trying to think if my patients have complained of anything else, but it's mostly just the bathroom. And just as a reminder, I didn't put this in my slides, but you take the larger dose first thing in the morning, and then you take the smaller dose mid-afternoon, and that should keep you from being up all night going to the bathroom. So I guess the second thing is going to the bathroom at night. I do have some patients, even though they're taking it correctly, they still are up at night. Thank you. I love all your questions. These are great, keeping me on my toes. Oh, I'm going to go to the last slide. There's my email address. Feel free to reach out to me, especially if I seemed less sure of your question. You can email me and ask me the question, and I will get with someone who's more of an expert than I am and get back to you.
All right, we still have a little time left, but I'll give you one last chance for someone to put some questions up. If not, we'll end a little bit early and give you time to take a break. I see the note just came out. Please answer the survey if you don't mind, so we can keep providing the best presentations to you in future.
Oh, I was asked about a best time of day to take hydralazine. So we try really hard with our patients to give hydralazine twice a day and hope that that will work, because 3 times a day drugs are incredibly difficult to take. I struggle with 3 times a day drugs. So if you take it twice a day with hydralazine, it's kind of best, as best you can, to take it roughly 12 hours apart. Not exactly. You could take it, like, say you get up in the morning at 7, take it at 7, and then at night take it after supper, 7. So it's like 7 and 7. If you need to take it 3 times a day, I have some patients who their blood pressure is sort of erratic, because maybe they take their first dose at 7 a.m. and then their second dose at 2 p.m. and their third dose at 5 p.m. And so they haven't exactly spread the hydralazine out throughout the day. So 3 times a day hydralazine is every 8 hours. Why do you have to take it every 8 hours? Because the drug doesn't last in your body that long. So if one of your dosing intervals is like significantly more than 8 hours, like 12 hours, then you're going to lose the drug effect during that 12 hours. So hydralazine, 12 hours apart, hopefully that'll work twice a day, because it's a lot easier to take it twice a day. If you have to do it 3 times a day, generally morning, mid-afternoon, and bedtime is how you get to every 8 hours. That's where a reminder on your phone is helpful. So I have students on rotations, and they often help my patients set up their smartphone with an alarm to take their hydralazine mid-afternoon, because that's hard to remember.